Hi. We're going to be looking at the shoulder at this moment. There are not too many manipulation techniques that we have to worry about. The shoulder rarely needs to be manipulated. But we will look at some short lever manipulations for the glenohumeral joint, an anterior thrust manipulation for the AC joint, and we'll also be checking over the quadrant movements and quadrant tests for the shoulder, including the lock-in position. And we'll start with the quadrant testing. So we'll have the patient lying down, and as you'll probably notice, we have a new model with us. This is Beverly Parrot, and we'll start with you now. Lie back for me. Okay, for the quadrant tests, we'll be looking at basically 4 quadrants with the addition of the lock-in position, which actually is a 5th quadrant. The trick with the testing the quadrants is good stability of the scapula. So for 2 of these quadrants, we will come underneath the scapula, grasp the spine of the scapula like so. We'll just move the pillar over a touch there, and pull the scapula downwards to stabilise the scapula. The first quadrant we'll be looking at will be lateral rotation, extension, and then we'll take the arm out into about 90 degrees of abduction. The second quadrant is a continuation of this. As we come up and over this position, you'll feel it roll over the joint surface, and then it will come up into the end of its quadrant like so. So this whole movement is from here into extension, lateral rotation, abduct it all the way through the range and up to the end range, and then return in the same quadrants. And of course what we're looking for is a normal ovoid of movement. So any slippages would indicate an instability. Any lumps and bumps that shouldn't be there would be hypomobility. The lock-in position for this is to take the arm into extension and medial rotation and then abduct as far as it'll go, and you should come up with a very abrupt end fill there, and it shouldn't be particularly painful. If you're not getting this, or if it's painful, then you have a positive lock-in position. Now, if we allow the arm to laterally rotate from here and take it further into abduction, this is actually a very sensitive impingement test. So anything that is capable of being trapped below the acromion by the humerus will be pinched at the point that it rolls into lateral rotation, like so. So it's one of the more sensitive impingement tests. The other 2 quadrants are basically in the anterior plane of the body. And for this, we'll need to stabilise the scapula by holding the lateral border of the scapula down onto the bed. And the first one we'll look at will be this one in the elevated position, which will be lateral rotation and adduction, and we'll flex and extend through that elevated range. Again, looking for that normal quadrant and no pain. As we come down into the lower part of this range, we'll hold it in medial rotation and bring it across the body into adduction, like so. Of course, these techniques, like all quadrant techniques, can be used as treatment techniques when there isn't anything else available for you, when the glides are okay and you can't find anything more definitive. In which case the quadrants are a non-specific technique and you scour at that end of the range. So for example, if I found that this part of the quadrant was missing, then I would gently work at that reduced range, not producing pain and certainly not overstretching this, but just working gradually at this range, and over a period of a number of treatments I would expect this to increase with the treatment. So we have the quadrants, very sensitive tests for the extreme combination of movements, the ovoid of movement, and also as a treatment technique for the non-specific hypomobilities that we can pick up with the quadrants. Such a good technique of picking up minor lesions that it's probably a better idea to put this at the beginning of the biomechanical examination as a screen for the joint rather than at the end, where it's usually used as a test of last resort. Okay. With Beverly in this position, we also need to look at a few manipulative techniques that are rarely done. There is rarely any indication for doing this, and usually mobilizations will take care of it. But if we're going to manipulate the joint, we need to do this with a very short lever, and we need to make sure that we are working through the plane of the joint, which is anteromedial, posterior, lateral. If we work straight anterior and posterior with these manipulations, then we're going to do damage to the joint capsule. So we'll get a sandbag and basically come in and support the scapula. So if I want to manipulate the posterior glide, assuming that's missing, then essentially, again, a short lever, I'll put my hand onto the humerus, have the scapula well maintained, close to the joint line, in just about exactly the same position that we had it for the mobilization. Basically take the slack up, and then it's a very short thrust through your arm. So it's just body weight, or part of body weight, not all of it, and just drop down through it. If I wanted to do abduction, then I could come into this position, bring the shoulder girdle down as far as it's capable, coming close to the humerus again, and basically inferior glide it. For anterior, I'll go around the other side of the bed. Come towards me. Thanks. And this time I'll stabilise the humerus, like so, and come onto the coracoid. So I'll take it to the end of range again, coming onto the coracoid, and I'll thrust the coracoid posteriorly, which is a relative anterior thrust of the humerus. Again, short lever, minimal thrusts. As I say, there aren't too many indications or times of necessity when you'll be doing these techniques. But if you need them, keep them very short lever and short thrust. The other technique is for the AC joint, where we'll be looking at an antral lateral thrust. We'll have the patient laying prone. And I'll be doing it from the opposite side of the body. This will make sure that my force is directed in the correct direction, anterolaterally. We'll stabilise the coracoid by bringing the sandbag underneath the coracoid, bring the upper arm across onto the bed like so, and then I'll put my thumb on the back of the clavicle and reinforce it with the other hand. And we'll just take up the slack, and actually the thrust comes through my right hand, through the thumb, again very short, like so. Again, this is not a joint that usually needs manipulating. In fact, it's not a joint that usually needs mobilizing. But if it does become hypomobile, generally speaking, we can deal with it using mobilization techniques rather than manipulative techniques. Okay. Well, these series of techniques completes the tape on the upper limb manipulations. If you're very careful with the manipulations, they're extremely effective, very safe. But the main thing to remember is that for the subluxation manipulations, the manipulation needs to be high velocity, low amplitude. Keep the amount of displacement to a minimum and keep your velocity fast. And this way you'll avoid any serious consequences from these manipulations. Thank you.